tip of the elbow and more medial responds to stress, especially in young people when you've got growth plates and so forth to deal with. This creates the bone spurs that creates the tension and the shearing forces on that UCL, and end up fraying it, tearing it, what have you. What do we do about that? Biggest thing is rest, okay? If we get somebody that has a UCL sprain, they're probably gonna be shut down for at least, this is 3 months, at least a month to 2 months of just complete rest. No throwing, go to PT, do exercises, make the environment good, don't overstress it. And then they'll take the next month or so to resume throwing activities, but you can't just go send them back on the mound. They've got to build back up through a throwing program. UCL surgery is what we were talking about earlier. Immobilization for a while, then range of motion. Progressive after about 3 weeks. They try to get them moving very quickly, to be honest with you. And then you're looking at full range by the end of 4 to 6 weeks. After 2 to 4 months, they can start some functional training, some strengthening, plyometrics, all this. But again, it takes a long time to build up to throwing again. This is a lengthy procedure here. We talked a little about elbow flexion contractures, low load prolonged stretch. They've got a dynamic splint. Trying to really take the time to stretch things out gradually. Elbow fractures, we talked a little bit about falling onto outstretched arm. Close reduction, it's usually going to be surgical, because if it's fractured, again, something that stable, it will tend to need surgery. It's not usually something they can just immobilize. A Volkmann ischemic contracture. Okay, this is where they get so much, the flexion contracture contributes to an ischemic, meaning a reduction of blood flow. That reduces pain, increases pain into the forearm. Very painful finger movement. I had one of these that was really puzzling. It kind of just snuck up on all of us. They were doing real well, and then all of a sudden, over the next week or so, lost some range, increased pain. I'm like, what is going on? Well, it turned out this was the problem. It was cutting off the blood supply. So they were really struggling to get any good blood flow distally. You can check that with, I remember this guy's he had blue fingertips. That's kind of what we looked at. That doesn't look good. So that's a very real entity. Intercondylar fractures, this is right at the elbow. They'll always be pinning these types of things. Radial head fractures we talked about, my mother-in-law. Olecranon fracture is usually just someone falling right on the point of their elbow, usually an avulsion, it just chips off. If it lines up okay, they probably just let it go. Otherwise, they'll put a pin in there for probably 6 to 8 weeks there if it's not displaced. Total elbows, we talked about. These are just the time frames. Again, very, very conservative, very slow progression with this. Doctors are very hesitant to push those folks. Lateral epicondylitis we talked about. I had pretty good results with iontophoresis to initially calm down the inflammation, get them working on stretching, and then eventually eccentrics, like we talked about. Anybody heard of a thing called a 10X procedure? Nobody? So, demo on that. So this is for tendinopathy as well. Minimally invasive procedure that removes scar tissue from your tendon. ultrasound guided percutaneous needle tenotomy. So they're just taking a needle, basically just going through the tendon, almost kind of like aeration of your tendon, if you want to think of it that way, to stimulate growth. You've heard of microfracture, right, for bones? A lot of times they'll go in, and some works better than others, especially for a knee that has cartilage that's worn away and so forth. Sometimes they'll do a microfracture where they'll go in and they'll just drill holes in the bone to try to stimulate growth. That's more or less what this is trying to do with the tendon. There's a doctor in Chapel Hill that did a good bit of this. Let me see if I got a video of this. This is an interesting. Let's just watch this. Yeah, this is all done through ultrasound guided. You see, he's just going in and just hitting the tendon with this little gun. And there's a protocol to follow for that. Prolotherapy was another thing. They were doing injections of saline to try to build up tissue in there as well. That's not as much accepted as this is now. All right, let's practice some moves. Who's going to be my hand model? Crystal Matus. And you're kind of loose though, aren't you?
Very.
Let's don't do that. Levi, he's my mobilization man. You got any problem with the, which, you got issues with the knee, right? Anything with the wrist?
Oh, no, I don't think so.
We're okay? Let's come over here. Levi, just grab one of those chairs. They make this blue wedge. It's just a piece of rubber, real thick rubber, and it's shaped like a little triangle. It's great for putting it something like this. I can't even think of what that's called, but we're just gonna make do with this. So what I'm gonna do is I'm gonna stabilize his distal radius and ulna, and then I'm just gonna start with just a distraction. I'm just taking and trying to separate his carpals, stretching out the ligaments. Really simple. And you can do it. You can have him kind of grab the hand if you'd rather. I don't like that as much though. I feel like I'm pulling all these bones and everything that way. I like to get it right about here. Feel some stretch there. I'll distract and then I'll glide. Yep. You feel that? Mm-hmm. Not painful, hopefully.
No. Different.
Yeah.
Sure.
Yeah. You can stabilize it this way. I've had people pin stuff down here, but you want to make sure that this is really stable so you can get a good distraction. And you glide that way. Now for the radial head, you'll probably want to come around this way. So if we're looking at, if y'all would agree, you can feel this radial head right back here. Right? So what I'm gonna do is I'm gonna make a okay sign. You can either do it index or middle, whichever works best for you. And I'm gonna take this here, stabilize distal humerus. Now this one's a little more uncomfortable. And I can work this way.
What exactly are you pinching?
I am getting on his radial head. So come around this way and you can see a little bit better. I've got my thumb. So to find the radial head, remember we supinated and pronated here. You can feel that roll. So I'm getting right on the radial head here. And I'm just trying, I'm going through a lot of tissue here. Just trying to mobilize here. Again, how'd that feel?
One of the best.
One of the best, yeah. I mean, it's more, you see how red he's getting there. It's just more uncomfortable because you're going through soft tissue here. Now, again, because this is so stable over here, I'm not doing anything there. I can't mobilize that, but I can do something over here. So this is what I want y'all to try. Radial head and carpals. And you can even do like a lateral glide. You can feel those, right? But again, think about really stabilizing here and just moving the distal segment. And you're gonna probably want a book or something here just to give you a little more of a platform. Okay? So work on these two for me.